Just make sure it pops up. Hello, everybody. Is anybody out there? We've got about, I think about 50 people here. Well, it says we are live, but I'm just checking the stream. It's not showing. Hello, can anyone see our video? That's definitely... Okay, we're live. Very good. Welcome, everybody. Thanks for waiting. We just had to get some issues sorted out there. And we have here Dr. Aovana Timmerman, specialist endodontist, here to present hypochlorite incidents. Just an overview of today's webinar. We'll hold questions till the end of the webinar. So if you have any questions, please write them down in the question box and we'll go through all of them at the end, okay? So Dr. Aovana Timmerman graduated in 2001 with a Bachelor of Dental Science and a Doctorate of Clinical Dentistry in Endodontics from the University of Melbourne. She finished her fellowship with RACDS in 2010. She's also received the J.M. Booth Award in 2013 to attend the IIDT Congress in Turkey. In regards to teaching, she's also involved in endodontic education in the past 13 years and was given a graduate certificate in clinical teaching award in 2019. She's also currently a clinical demonstrator and examiner. Welcome, Dr. Timmerman.
Thank you, James, and thank you, GDR, for inviting me to give this webinar.
Lovely. So I'll leave with you, Dr. Timmerman. So if you could pop your slides on, and we'll get started. We're hoping to finish around 8:30, everybody, if you are wondering how long this will be, including Q&A.
Okay.
And thanks.
Can you see the slide? Yeah. Okay, cool. Let me just see. Let me just check this. Okay. So everyone, thank you for attending this webinar. And my topic today is sodium hypochlorite incidence. The reason why I call it...
I can't see your slides yet.
Okay, let me just check. Okay, yeah, I should be able to.
Okay.
Okay, good.
That's good. All right, thank you.
Okay, sorry, I'll start again. So welcome to my webinar on sodium hypochlorite incidence. And the reason why I call it a sodium hypochlorite incidence is because I do believe that you can avoid this incident. And it can be a very stressful situation. And many years ago, I actually had a phone call from one of my past students who encountered this, and she was really quite stressed. So she rang me up close to Christmas Day, and then we had a really good chat about it. And that prompted me to present this lecture for Melbourne Uni subsequently. You know, and I don't think currently there's any other endodontist in Australia that's presenting this topic. So if you actually follow me on Instagram, or if you know me through social media or through the university, you know that I'm very passionate about endodontic education. And if you do share on any of my slides on social media, I do request that you post a story with a learning point attached to it, so that others watching your stories can learn from my lecture as well. And tag me. Thanks. So in the next 45 minutes, I hope that you're going to learn how to recognize, manage and prevent sodium hypochlorite incidents? So first of all, let's define the problem. When we encounter a complication in dentistry, it can be really quite stressful, and it can be confusing as well for a lot of people because you'll be wondering why this complication has happened. But first of all, let's define the problem. What is exactly a sodium hypochlorite incident? So in many years of practice, I have definitely been splashed by sodium hypochlorite solution multiple times, and it can become quite an expensive problem. But this is not what we're going to look into today. And these are the type of sodium hypochlorite incidents we are quite concerned about. The majority of case reports describe cases where there is forceful extrusion of sodium hypochlorite beyond the root apex into the perireticular regions. And with extrusion of sodium hypochlorite into the maxillary sinus, it becomes more likely if the root apices are projecting into the sinus. And these root apices could be protected by just a thin layer of bony lamella and sinus membrane. With injection of sodium hypochlorite solution, it's really quite rare because most practitioners will not be preparing their own local anesthetic solutions in the clinic anymore. And if we look at the prevalence of sodium hypochlorite incidents, it's actually quite rare in endodontic practices. There was a survey conducted by the diplomats of the American Board of Endodontics, and they found that approximately less than half of the diplomats have encountered a sodium hypochlorite incident. But I always find that the bad experiences are often reported less in dental literature and more commonly reported, among friends or among colleagues. So it's actually more common in real life. So if we look at, a recently published article by the Australian Dental Association in South Australia, sodium hypochlorite incidents are actually the second most reported endodontic complication by general dentists, and unsurprisingly, it can lead to complaints. There was another paper published by Australian researchers which looked at data extracted from APRA from 2016 to 2017, and they found that these endodontic events may trigger off complaints. Unsurprisingly, in this list, you'll find perforations, separation of instruments, and also extrusion of irrigants as well. In this paper as well, it was interesting for them to classify extrusion of droplets of fluid into the periapical tissues when using normal irrigation methods as an accident, where if you have a perforation and you fail to recognize and manage it, it's considered as negligence. And if you fail to inform the patient of possible complications, such as sodium hypochlorite incidents or the consequences of your treatment, that's considered as malpractice. So what could be the consequences? If we look up, news on the internet, we'll find that there's a lot of patients who are awarded a lot of money after sodium hypochlorite incidents, especially in the UK. So this patient, her face began to swell, and she was admitted into hospital in an ambulance after having routine root canal treatment. And that's quite a significant compensation. And there are similar newspaper articles where there are patients being awarded money for compensation if they have suffered paralysis, could be temporary or it could be permanent. And in Australia itself, the Dental Board of New South Wales have had a report where, a dentist was cautioned when he encountered a sodium hypochlorite incident when he was carrying out endodontic treatment for an upper molar tooth. And in the end, the board accepted that the complaint did not warrant a finding of unsatisfactory professional conduct, and just cautioned the dentist to ensure that he remained current in his treatment of patients and his knowledge of endodontics, and also refunded patient the fee for the treatment. But in 2017, there was a patient who actually developed a facial deformity and slurred speech after having root canal treatment with a dental student that was supervised by a dentist. And the patient subsequently sued the university for over $500,000. So, it can become quite an expensive lawsuit for any dental clinician. And even on social media, we still get a lot of dentists in Australia wondering about what to do when they encounter such an incident. So I guess we need to know more about it. So what are the signs of sodium hypochlorite incident? So this is a very classic presentation of sodium hypochlorite incidents. And the patient usually experiences immediate intense pain and swelling. And it can also occur minutes or hours after the procedure. And there's usually immediate swelling as well. So in the picture B, you can see that the patient's face is obviously quite swollen. And that was immediately after the dental dam has been removed from her mouth. And you can also often get profuse bleeding from the root canal during irrigation. And you can get ecchymosis or hematomas, which indicates interstitial bleeding of skin and mucosa. The patient may report chlorine taste or smell, and you can also see the disappearance of the irrigant into the root canal instead of a backflow. So when we actually look at the pattern of ecchymosis in case reports, it is actually universally present along the angle of the mouth and around the periorbital region most of the time, which correlates with the drainage of infused sodium hypochlorite solution along the course of the superficial venous vasculature. Occasionally as well, the ecchymosis can actually extend to the neck and chest as well. You can also get mucosa and bone necrosis or neurological implications such as anesthesia or paresthesia. And it is quite rare, but it's also possible to get a mucosa chemical burn on the chin with leakage of sodium hypochlorite solution from the rubber dam during treatment. And for this case report, it took about 3 months for the skin discoloration to actually resolve. So it can be quite disfiguring for the patient as well. And there are, of course, other case reports that talk about dysphagia, dyspnea, necrosis of the tissues, and trismus as well. When you're actually assessing a patient who has had sodium hypochlorite incidents, I think it's good to have like a guideline for what to look for so that you can actually write down very detailed notes in your records. And in this review paper, it actually states in extraoral exam what you should be writing down or what you should be checking for, and intraoral exam, what you should be looking for as well. So I find this really, really helpful. There are potential predisposing factors for sodium hypochlorite incidents, and we need to look out for them. So according to a survey done in 2008 in America, they found that it was more commonly encountered in maxillary teeth compared to mandibular teeth, more commonly encountered in premolars and molars compared to incisor and canine regions, and more commonly encountered in female more than male patients, maybe because there were a lot more females seeing the dentist for treatment, and also more common in teeth with pulp necrosis and periapical radiolucency. And also we have to consider that, when you are treating maxillary posterior teeth, like for example, the second maxillary molar, the distance to the maxillary sinus might be lesser compared to other teeth. So that's something to look out for when you actually look at the radiograph, look at how close potentially the root apex might be to the maxillary sinus. And there are, of course, iatrogenic factors as well. For example, if you encounter a tooth that has been restored with a crown, it's often more challenging to locate the pulp chamber, or if you have calcification within the pulp chamber or in the root canals, you're going to find that it's going to be much harder to locate the pulp chamber or root canal. And often this type of scenarios happen because the clinician really tried very hard to search for the location of the root canal. So now I'm going to go through a clinical case that I have encountered, so we hopefully can learn from this case. So this is a patient who was asymptomatic when he saw me, and he was referred by a dentist who suspected a sodium hypochlorite incident on tooth 1-4 when carrying out the treatment for him. The dentist noted in the letter that when the suspected incident occurred, the patient experienced severe pain and swelling during irrigation with 1% sodium hypochlorite solution after she has instrumented the root canals. She then flushed the root canals with saline and then noted a clear fluid flowing out from the root canals. So according to the patient, he felt this severe burning pain and swelling on his face immediately after root canal treatment with his dentist. And he was prescribed amoxicillin and metronidazole. But the swelling became worse overnight, and he actually ended up in the emergency department of a medical hospital. He was then prescribed more medications, but he couldn't remember the names of those medications. But what the patient was really frustrated about was that he did not understand why endodontic treatment was even commenced on the tooth, as it was asymptomatic prior to the treatment. The patient was uncertain about continuing the treatment, and he did not wish to return back to the referring dentist because he was quite traumatized. So you can see that this is a historical periapical radiograph taken by the dentist in 2014. There is certainly elongation of tooth 1-4 in the radiograph due to the vertical angulation of the X-ray cone. Also, the film could have been positioned more apically such that more of the periapical area around the root apex could be captured. And you can see that there were two hand files placed in the root canals. They both appear to extend beyond the radiographic apices by approximately 4 to 5 millimeters. However, I could also see why the dentist would be misguided by the radiograph, because it showed two curved radiolucent lines which appeared to be where the root apices were, as highlighted by the yellow arrows. And again, in the historical cone-fit radiograph taken by the dentist, you can see that the GP cones appear to extend beyond the radiographic apices. And when I asked the dentist, did you actually use an electronic apex locator? The dentist actually said yes, she used it. So on the day of my consultation, I found that from the examination that I carried out, there was healthy periodontium around the tooth. The tooth 1-4 was restored with cavities in the occlusal access cavity, but there was a dislodged restoration on the distal occlusal surfaces, and it was not tender to percussion, it was not tender to palpation. The mobility and periodontal probing depths around the tooth was actually within normal limits. And these were the radiographs I've taken. And in the tooth 1-4, you can see on the radiograph on the right side, you can see that there's a periapical radiolucency present around the palatal root apex. It's quite difficult to define the PDL space around the buccal root apex due to the density of the bone trabeculation. But the length of the roots of tooth 1-4 appear to be shorter than the neighboring tooth 1-5. So based on the history provided by the patient and the dentist, and looking at the radiographs present in the patient's records, I did suspect that a sodium hypochlorite incident had occurred during the past endodontic treatment. There was also tooth structure loss on the distal surface of tooth 1-4, which was most likely due to caries or marginal leakage, which could have led to bacterial ingress into the pulp. And from looking at the historical radiographs, the dentist did not have the right working lengths for both root canals and may have positioned the irrigation syringe such that it was either locked within the root canals or placed beyond the root apex during irrigation after preparing the root canals, which then resulted in the sodium hypochlorite incident. So you can see my working length radiograph, and you can see exactly where the palatal root apex is from where the yellow arrow is pointing. And there could have been also some external inflammatory root resorption, which can actually enlarge the root canal apically and therefore increases the risk of a sodium hypochlorite incident as well. And this was my confit radiograph. And you can see that because the root canals could have been potentially over-instrumented in the past, what I did was I placed the GP cones that fit well and had a good tuck back, and sort of work out the apical size I should prepare them to. And this was the post-op radiograph that I took in September 2014. So what are the lessons learned from this case? First of all, always discuss the complication in your consultation. If there was a history of a suspected sodium hypochlorite incident, do discuss ways that you can prevent it from happening again with your patient. Provide profound local anesthesia during your treatment, and never assume that the electronic apex locator would be 100% accurate, and retake your working length and cone fit radiographs if needed. And also explain to the patient that this complication does not lead to a poorer treatment outcome. And how would you manage a sodium hypochlorite incident? So this is actually a summary of management strategies that I took from lots of different papers. First of all, always let the patient know what is happening and reassure the patient. Pull back on the irrigation syringe and aspirate out the irrigant. Dilute the sodium hypochlorite solution with either local anesthetic solution or saline. And also consider administering more local anesthesia, or recommend patients to take analgesics straight away. And in Australia, I think we generally have odontopaste in the clinic, so I don't think it's any harm using odontopaste in the root canal because it contains corticosteroids. And consider advising the patient to use a cold pack in the first 24 hours to reduce pain and swelling. And on the second day, the patient can start to use a warm pack and warm saline rinses. And prescribe the patient with antibiotics. And it's also a consideration to prescribe the patient with corticosteroids to take for short term. And I think it's a good idea to consider referral to an endodontist and or oromaxillofacial surgeon. And what happens is if you do refer to an endodontist, we then can decide, okay, maybe we should also liaise with an oromaxillofacial surgeon as well, or the oromaxillofacial surgeon may liaise with other medical specialists, such as a plastic surgeon, for example. This is the guideline from therapeutic guidelines in terms of pain management. And for severe pain, I do recommend taking ibuprofen and paracetamol and oxycodone as well. But I guess, pain tolerance and pain threshold is different for everyone. So I guess the best thing is to liaise with your patient and understand the amount of pain they're experiencing before you recommend analgesics. With the use of antibiotics, it's very empirical in dentistry because we don't really know what we are targeting exactly. But the premise of using antibiotics is based on the fact that you're going to have tissue necrosis. So there's a likelihood of secondary infection. So I would recommend either penicillin with metronidazole or amoxicillin and carbapenem, or clindamycin if the patient is sensitive to penicillins. And when should you consider referral to an oromaxillofacial surgeon? I think when the grade of injury is considered as moderate or severe, when there's intraoral ulceration or intraoral necrosis, or when the ecchymosis is diffuse and pain is severe, I think that's always consideration that you should refer to an oromaxillofacial surgeon. If it's mild, yes, definitely we can help out, but we can also advise you if endodontic treatment can be continued and figure out with you what could have gone wrong during the treatment and how to avoid this from happening again. So what about the expected healing time? So with pain, swelling, ecchymosis, hematoma, tissue necrosis, it usually took a couple of weeks to a month. Mucosa healing took up to about 2 months. And there was one report of swelling that took up to 4 months to resolve, which was quite an extended period of time. And also, if the patient develops fibrosis, scar tissue, altered sensation, that could actually be quite prolonged, up to even 1 year follow-up. And the psychological impact on patients could be quite long-term. And so how can we prevent a sodium hypochlorite incident? So it will be the best thing to do if we can actually prevent it. First of all, you need to figure out whether the case is simple or complex. And the case difficulty assessment, we look at the patient itself. Patient factors can influence treatment, diagnosis, and tooth factors as well. And at Melbourne Uni, we do have this very simplified case difficulty assessment form, but it's actually based on the American Association of Endodontists case difficulty form, where we look at patient factors, diagnosis, and tooth considerations to work out whether it's going to be a simple or complex case. So do study your preoperative radiographs very carefully. So consider whether you have good access to the pulp chamber, first of all, and consider whether you have good lighting and magnification as well, which can all help you to locate the pulp chamber to prevent a perforation. And consider when a perforation can potentially occur. So usually during the access of a tooth, when you are trying to locate the pulp chamber, and if the tooth had, extensive gouging in the past, it's going to be easier for you to perforate. Or if you find it difficult to locate the pulp chamber or root canal, that can also lead to a perforation. Or even when there's presence of root resorption, or when there's very extensive caries that actually extend into the pulp chamber and root canal. With instrumentation, I guess what is really challenging at times is to determine the working length. Don't be afraid to take a few more radiographs if you need to confirm the working length. And also, if the root canal is quite large, for example, you have a tooth with root canal with a large root canal with an open apex, or there's root resorption, that can increase the chance of extrusion of sodium hypochlorite solution. Or if you're trying to bypass a fractured instrument, or unblock a root canal and trying to force the hand file through, you might actually create your own root canal, so a perforation. And also, if you're trying to prepare a post base and it's misdirected, or if you select a post that is too large in size, that can also cause a risk of perforation. So when you also take on, a case to manage as well, do look at the radiograph very carefully, because you can find that in some cases there will be a past history of perforation as well. And it's not uncommon for me to see that as an endodontist. Usually for a maxillary anterior tooth, the perforation is on the buccal surface, and with actually a maxillary premolar, usually it is actually on the medial surface. And always look for gouging or likely perforation, as in this case, the dentist obviously had a lot of difficulty locating the distal buccal canal and wasn't sure whether he has actually located it, so decided to refer the patient before causing a perforation. There are also different types of root resorptions that can be associated with a perforation as well. Sometimes you can get external inflammatory root resorption that actually communicates with the inside of the tooth. So look out for these cases as well. With detection of a perforation, there are a few ways to do it. First, get the dental history and look for radiographic signs. And look for sudden bleeding when you're actually assessing the pulp chamber or the root canal. And use a paper point as well, and to dry the root canal, have a really good look. And use your electronic apex locator. If you're getting a reading at a very short length when you're expecting the working length to be a lot longer, then it tells you that something's not quite right. And think about the angulation of your hand file. For example, if I insert the hand file into a distal canal, I would expect that the handle of the hand file to tilt medially. So if it's not angulating correctly, that is also a hint. When in doubt, do take a radiograph. And also, try using another irrigant instead of sodium hypochlorite solution if you're uncertain whether there's a previous perforation. So with the toxicity of sodium hypochlorite solution, it's really related to its chemical composition. We know that it's great as an antimicrobial agent and actually really great for tissue dissolution. But unfortunately, it's very cytotoxic, especially to proteins. And it also causes hemolysis. Definitely a higher concentration of sodium hypochlorite solution is going to be more likely to cause a sodium hypochlorite incident that's more severe. And also the volume of the liquid extruded as well is also going to impact on the amount of tissue necrosis. And interestingly, the minimum volume found to cause a sodium hypochlorite incident was 0.5 mils. And that's a very small amount of sodium hypochlorite solution. And also the pressure of extrusion. So if you're forcing the liquid down into the root canal and not being gentle, that can then increase the risk as well. But why don't we use another irrigant like, chlorhexidine? Because it doesn't actually dissolve tissues. So that's why we still stick with sodium hypochlorite solution. So with irrigation technique, always make sure that the irrigation needle feels really loose inside the root canal. Use a side venting needle and use it in a very gentle jiggling motion, and really, really take it slow when you're actually pressing the sodium hypochlorite solution out. And, when we look at, fluid dynamic study, it's very obvious that we should be using side venting irrigation syringe needle. It's a lot safer because it doesn't extrude as much liquid out compared to the end venting irrigation syringe needles. And also, if you use a sharp needle with the sharp tip at the end, it's possible that that can perforate through soft tissues as well. And always I like, to teach other clinicians to actually ban, the irrigation syringe needle, so you know exactly where you're going to. And I'd like to stick to at least, 3 or 4 millimeters away from the working length once I get my working length measurement done. You can also attach a stopper at the end of your syringe needle as well if you have a, say, a very short root canal. With irrigation technique as well, when you're holding, the syringe in your hand, if you are very heavy-handed on your thumb, it might be better to switch to your second finger, index finger, so that you actually put less pressure on your syringe when irrigating. So you have to work out what works best for you. For me, I like to use my thumb, but I'm very, very gentle on my thumb. And actually, when I'm managing a tooth with a perforation, I actually wash the sodium hypochlorite solution over the perforated site. So I'm very, very careful, and I can see exactly how much liquid I'm pushing out. So how about using like passive ultrasonic irrigation or sonic irrigation? Does it matter? Does it make it worse? If you use it to within 1 millimeter of the working length, it seems to be fairly safe. But, do expect that, there could be potentially some minor extrusion of irrigants in straight or curved roots. And if you have a root canal, which is larger in apical size, it means that there's more likelihood of extrusion. Also consider your dental dam isolation as well. I like to make sure that the holes that I punch on the rubber dam is small so that it actually hugs around the tooth. And there are also other examples from other clinicians as well, where they use like a caulking agent, like, Orasil to seal around the tooth. Just be super careful when you're using a split dam technique, because there could be gingival that is actually exposed, and there could be leakage under the rubber dam in those areas. But also having an assistant there for you to help you to suction very close to the excess cavity, maybe with a surgical suction tip, is going to be a lot safer as well. When you're irrigating, always look for the backflow of irrigant. And if you notice something unusual, like for example, the liquid disappears or there's bleeding suddenly, do stop and figure out what is going on. Also, with working length measurements, do take care when you're using an apex locator, because sometimes it can give you an inaccurate measurements, especially in a tooth with a large open apex, or when you have a tooth with a horizontal root fracture, for example. And also consider taking radiographs at different angles if you are not sure about the length from one radiograph. So what can you do differently when carrying out endodontic treatment tomorrow? First of all, you can determine the case difficulty. Watch out for an open apex, gouging, perforation, or roots resorption. Improve on your isolation technique and use sodium hypochlorite solution carefully, and consider your irrigation technique whether it's safe. And inform the patient well in advance regarding the potential complications or risk, and document in your dental records. So there was this paper that was published not too long ago that actually gave, everyone a chart on, what to do if you do encounter such a situation, in case if you need to refer the patient. But I think it's really useful to have a guide, in your clinic, where you can just follow it to write down, the information that you need to document. Because we probably encounter this incident very rarely, so it's very easy for us to miss out on details. So these details include general information, treatment details, patient signs and symptoms, and what the management was, by your team. There are a few review papers that I would definitely recommend to read, and I'll be happy to share, these papers if you like to contact me, and I'll be happy to email that across to you. So if you have any questions, feel free to ask, and if you wish to locate me on social media to ask more questions, this is my Instagram handle. Thank you.
Thank you so much, Dr.
No
Timmerman.
problem.
Let me just change the view here. Lovely. I have a question for you. You mentioned about toxicity of sodium hypochlorite if you do get into an accident. What's your preferred percentage of sodium hypochlorite? Does it affect the way you choose like a high or a low, keeping that in mind of maybe getting an accident?
I think like it really depends on who will be using it at the practice, and in general we tend to use a higher concentration of sodium hypochlorite solution among say endodontists compared to I think general practitioners. So I mean my preference is about 4%. I'm not sure what you use in general. What do you use, James?
We also have 4%. Yes.
Okay. Yeah. Just because it's actually going to have a better tissue dissolution effect. But in terms of antimicrobial effects, there's not much difference between a 4% and a 1%. So I think that if you stick to a lower concentration, it just reduces your risk. But for us, I guess we just want to disinfect the root canals as quickly as we can, so we stick to a higher concentration usually.
Yeah,
Mm.
makes sense. We have a question from NN. Should we send the patient straight to hospital if we get an incident?
I think it really depends on also the medical condition of the patient as well, and also whether there's any sort of related health issues. But I would definitely, if I feel like the patient is having some dyspnea and swelling that is getting a lot worse, then I probably say, considering the medical condition and the difficulty with breathing or speech, then I'll probably then refer the patient to a hospital. Yeah. Usually you would do that more in more severe cases. I haven't encountered actually a case that is that severe that you have to send the patient straight to the hospital.
Yeah, so it's like really extreme.
More extreme cases. Usually what I would suggest doing is definitely, give your friendly endodontist a phone call and your oromaxillofacial surgeon a call as well, just to see what they would suggest doing apart from what you have already done. So I think that will be a start.
Awesome. Thank you for that. We've got another question here from Pei Yuan. What would be the suggested timeline for recalling after these accidents? Is it 3, 7, 1 month? What do you like to do?
I definitely recommend recalling the patient on a very sort of close timeline. So I think 3 days, 7 days, then a month is a good amount of time to recall the patient, so that you can actually understand what is happening, and also get the patient to take photos if they can, to send it to you as well, so to see how they're progressing with the healing process. Yeah. And also, I think when such an incident happens, it's quite distressing for the patient and also for the clinician as well. So keeping a very close eye and close contact with the patient is a good idea.
Yeah, I think if the patient knows that you're caring about them and you're following up, I think that's less likely to result in litigation.
Yeah. So far, I mean, I've worked with really, really caring clinicians. I haven't actually seen a case where, for example, if they had a perforation or the sodium hypochlorite incident, I haven't seen a case where the patient would like to make a complaint. Actually, the patient was quite understanding because they were informed about this complication, and they know that this was a bit complex, for the dentist to manage as well, because in some cases, it was too difficult to find the root canal without a microscope, for example. Yeah.
Yeah. No, that's good. We have a question from a dental student, I assume. What's the best way to prepare your first endo treatment? Using plastic models can only go so far.
What is the best way to prepare for your first endo treatment as a dental student? I really like my students to send me a plan of what they would like to do step by step. so that I can, be informed as a demonstrator about what they're thinking in your mind, what they're going to get, what they're going to use, what they plan to do. And I think that, liaising with your clinical demonstrator very closely and sending them a plan is a good start, so that they can point out to you if there are any areas that you should be looking out for, anything that you haven't thought about. So, and also the other thing too is if you prepare a document for your demonstrator to read, and if it's corrected, at least you have this document to, look back upon and reflect and think, okay, what did I miss out and what could I have done differently, in your treatment process. So I think that would be the best way to prepare for the first endo treatment. It's going to be a learning curve for everyone when they start doing endodontic treatment for the very first time. But, my suggestion always is, be as prepared as possible, but just be prepared to plan for the unexpected.
Yeah.
Yeah.
I would agree. I would agree. It's
Yeah.
hard to yeah. And if you have actual teeth, you can collect and practice on them as well. That would be a good one as well, Val.
Yeah. Extracted teeth, but extracted teeth or plastic teeth can only go so far, really. Yeah.
That's right.
Mm.
Okay, next question from Lee Chong. Dilating the solution with saline after an incident. Did you mean injecting saline into the root canal system?
What I mean is, fill up the irrigation syringe with saline instead of sodium hypochlorite solution, and just irrigate with the saline.
I see.
Yeah.
Great. We have another question here. If you have a resorbed root with a wide apex, how do you prevent extrusion of materials?
First of all, if you're uncertain about the length, the working length, maybe it's good to use saline as an irrigant at the start. Figure out the length first. Okay. And then once you figure out the length of the root canal, then you really have to, measure your irrigation syringe needle and make sure it doesn't go, close to the working length. I would try to stay away from the working length by about 3 to 4 millimeters, or about maybe even up to 5. And then just irrigate very, very slowly with the syringe needle when you're irrigating, very gently. Yeah.
Yeah, very, very gently. We have a question from Dr. Clem. Hi, Dr. Aovana. Would you order a CBCT immediately after the incident to assess any structures impacted?
I wouldn't. And I think, with assessing the structures impacted, you can usually assess it clinically, like, swelling, ecchymosis. I don't think you need CBCT to assess that, because, with sodium hypochlorite solution, it mainly affects the soft tissues. So yeah, no. But if you're trying to figure out why the sodium hypochlorite solution has happened, and you're not sure whether there's a root resorption, say in the middle of the root, then maybe I would consider a CBCT in such a situation. But it has to be something quite unusual. But I wouldn't recommend a CBCT routinely after an incident.
Yeah, I just assume the management would still be the same.
The management would be the same. It wouldn't change the management. But if you're trying to figure out why this has happened and you're not sure, then maybe having a clear idea of the anatomy inside the root canals can give you a clue.
Yeah, awesome. Thank you. We have another question here from Angie. Follow-up question on saline. How do you confirm working length with saline?
So when you're confirming the working length, what I mean is that you use, the electronic apex locator and your working length radiograph. And if you're uncertain whether, you could have a perforation, for example, then you will use saline to irrigate the root canal in place of sodium hypochlorite solution until you confirm that there's a perforation, for example. Yeah.
Good point there. We have another one here from Dr. Sharma, would you ever suggest the use of sodium and chlorhex together?
Um,
I'm
and,
sure you can read the rest of that as well. Yes.
yeah.
Any scenarios where this may be recommended, and what about potential risk of chlorhex and sodium hypochlorite together?
I would never mix the two together because it actually forms this compound called parachloroaniline. I'm not sure whether you heard of it. It becomes like this toxic compound, which doesn't help with the disinfection process. The thing is, like, when you use sodium hypochlorite solution, you obviously want it to work effectively with the chlorine ions, and if you actually combine two different irrigants together, you're going to reduce the antimicrobial effects of sodium hypochlorite solution and potentially also the tissue dissolution effect. So for that reason, you wouldn't combine it with other irrigants, even EDTA. Unless you're just before obturation, you're trying to remove the smear layer, then you can use your EDTA. But usually during instrumentation, I would just stick to sodium hypochlorite solution.
Yep. Perfect. We have another question from Zihao. All right, do you have any advice on where to see where the roots are on a PA during working length and cone fit? E.g., figure out where the roots end for 1/6 if they are overlapped.
Yeah. It's a very common problem, and what I found really useful is to consider doing like a mesial shift. Say for a maxillary molar, do a mesial shift, and then you can see the root apex of the distal buccal root a lot better. And then do a distal shift to look at the mesial buccal root apex.
Yeah. Perfect. So using that slob rule.
Yeah, that's right. That helps a lot. Yeah.
Excellent. We have a question here. Would you use chlorhex on its own as a safe irrigant when working length?
I guess you can use it as an irrigant when you're working out the working length as well, but I mean, it just depends on what your clinic has. I think most clinics would have saline. So that's why I mentioned saline as, something that you can use. I guess you could, but just make sure that you don't combine using it together with the sodium hypochlorite solution.
Yeah, perfect. We have a question from Mariam. How do you usually communicate the risk of sodium hypochlorite incidents with your patients?
Yeah, so I think the first thing I would discuss with the patient is whether there's any factors that could make treatment a lot more complex. For example, like if there was a tooth with a large root canal and open apex, I will actually explain to the patient that there is a higher chance that the solution that we use to clean the root canal could be pushed out of the root canal, and also the medication. Even when we're instrumenting such root canals, it's possible for us to push a bit of debris or bacteria out of the root canal as well. So that's something that I would definitely mention to the patient.
Very well explained. We have another question. Do you have any advice on how to keep your caulking agent in place? I find that once it's around the clamp, it tends to come off with a high-speed suction.
That's a good question. So what I like to do is to dry the area around the tooth really well before I apply it. And then once it's placed in the area, I pack it in place with the dry micro brush or with the cotton palette. So I try to pack it down. That seems to keep it in place.
What I like to do is I like to open one side of the rubber dam clamp and let the rubber dam slide up beneath the clamps, and doing the same on the other side. But it takes a bit of time, but whatever works for you.
Yeah, that works as well. But that's a good tip.
Yeah. We have another rubber dam question. When you're punching holes for your rubber dam, do you use a guide template? And what tools are you using, I suppose, for the rubber dam?
I think using a guide is helpful, but because I've done it so many times, and most of the time I just do single tooth isolation. So in most of my cases, I don't actually need a guide to punch one hole in the rubber dam. But if I'm punching multiple holes, then I do it just by freehand because I'm so used to doing it. I can just eyeball where the holes should be. This is something that comes with practice and experience. Yeah.
Start off with a guide. Yeah, start off with a guide.
Yeah.
For your first few hundred rubber dams, but then you'll get a feel of how many holes you need. If you need 1, 2, 3, or 4, however you need. Lovely. I think we'll call it that. I think that's all the end of our questions. Thank you so much, Dr. Aovana. Just before we all leave, I just want to plug our stall at ADX. So we will be, Alex, Tasha, and I'll be there on the first 2 days, and Tasha and Alex will be there for the first all 3 days. So come by, say hi. We've got some promotions going on, and we're also launching next year Endo 12-month program. So check us out for more details while you're there. Thank you again, Dr. Timmerman, for sharing your wisdom. And please, everybody, if you want to send her any questions, please reach out to her on Instagram. I'm sure she'll be happy to reply.
Thank you. I'll try my best. I'll try my best. Thank you.
Thank you, everybody.